for that. With that aside, go ahead, Ania.
Okay, great. Thanks everyone for coming this morning, and I thought this would be a good topic for all of us to review. I find it very relevant to practice. So as soon as I figure out how to advance my slides, okay. I have no disclosures. And so the outline for the talk today is start with a broad overview of causes of secondary immunodeficiencies. Then we'll focus most of the talk on secondary hypogammaglobulinemia, which is probably the most common type we see in clinic. Go specifically over a recent set of updates that the QuadAI has released on management of secondary hypogammaglobulinemia, and time allowing finish with just a few illustrative cases. So starting off with this, listed here is just a few abbreviations that I will use throughout the presentation. I think we're all quite familiar with this, and I also kind of spell it out as we go along, but this is kind of to refer to if needed. So very broadly, secondary immunodeficiencies can be caused by many different things. The little cartoons here on the side are to depict that many of them are secondary antibody deficiencies, but there are also some that result in cellular dysfunction or both. So kind of broad categories of this are immunosuppressive and immunomodulatory treatments, various types of malignancies, transplant and associated treatments, infections such as HIV. There are acquired neutralizing anti-interferon gamma antibodies, good syndrome, immune senescence. As we age, the immune system also loses certain functions. Splenectomy can in itself lead to a certain type of immunodeficiency. And then other broad categories are things like protein-losing states, also simply impaired barriers where you can lose, serum or proteins and therefore become hypogammaglobulinemic. Also metabolic diseases and simply malnutrition. Just a quick word, this is only slightly about primary immunodeficiencies, or the preferred term right now is inborn errors of immunity to encompass their very varied presentations. But in workup of secondary immunodeficiency, we should not forget about possibility of an inborn error of immunity, because many of these secondary immunodeficiencies can be similar in presentations to primary immunodeficiencies, with diverse phenotypes of increased susceptibility to infections, but also patients having potentially malignancy, inflammation, autoimmunity, severe allergies. And just an update, every few years, the IUIS releases an update on the non-monogenic inborn errors of immunity, and they had a fairly recent paper with an updated set of those disorders. So just for your awareness. Now, in terms of secondary hypogammaglobulinemia, which we'll spend most of the talk on, so we all are familiar with the definition. It's here: reduced immunoglobulin levels due to a medication or a disease process leading to a decreased antibody production or increased antibody loss. So conditions that can be associated with this are listed here. And on the side, I kind of really pointed out to be mindful of the process that leads to this. So with hematology, oncology, such as lymphoma, CLL, multiple myeloma, the secondary hypogammaglobulinemia is due to malignancy-associated decrease in protein production. In protein-losing states, obviously, due to protein loss. In terms of in the other broad categories of conditions associated with secondary hypogammaglobulinemia, like in rheumatology, neurology, pulmonology even, that's less clear. We do see hypogammaglobulinemia often in patients with these conditions, but it's oftentimes not clear if that's secondary to the underlying disease process or medications they're on, or both. And so that still needs a lot more investigation. Now, moving on to medication. So just FYI, a large part of my talk will be really diving deep into the 2022 paper, which is the QuadAI updated recommendations on management of secondary hypogammaglobulinemia. And so that includes a very nice list of tables kind of with references for different types of medications causing secondary hypogammaglobulinemia. And so good reference. I think we see some of them more often than others, obviously. But so I don't want to go through this in detail, but they're divided into monoclonal antibodies, starting out, of course, with anti-CD20 therapies, which by definition lead to B-cell depletion and hypogammaglobulinemia. But there are some other side effects to keep in mind, such as late onset neutropenia that has been reported with rituximab. Looking at other monoclonal antibodies, I just highlighted a few things, but there's basically every single point is irrelevant. So really effects will vary on the immune system and the extent or timing of hypogammaglobulinemia associated with these therapies. For anti-CD38, for example, by definition, it targets plasma cells. And so it will, in terms of when we think of the patient and how their immune status will be affected, it will be a bit different than patients on, say, anti-CD20 therapy. Moving on to the next big category. So this is just broad immunosuppressants, corticosteroids. Again, we are all very familiar with this, but they can really have a variety of immunosuppressive effects. And they are not the same for a patient. So they can greatly vary. You can see hypogammaglobulinemia can be present between 12 and 56% of patients on prolonged high-dose corticosteroids. It seems that IgG is more affected than the other immunoglobulin classes. The specific antibody responses are typically preserved, so an important thing to note. CD4 lymphocytes can also be decreased. Other notable mention here, so mycophenolate, cyclophosphamide, they seem to be a contributing factor to increased risk of secondary hypogammaglobulinemia for patients who are already on rituximab. And the last category that
Ania, can I ask you a question?
Yes.
Go back with corticosteroids. I don't usually think that we're causing secondary immunosuppression. So what kind of doses and what kind of duration before you see an effect?
So the high dose, it can vary, but really it's really anything above 20 milligrams per day. The duration, I apologize, I don't know specific time, but it will be 2 weeks or longer. But it's certainly very variable, and not everybody will develop this.
Okay.
In terms of this, I just brought up not something I see often, but there is a well-defined association of antipsychotics and anti-epileptics with potentially causing hypogammaglobulinemia and other types of immune derangements like decreased class switching. And for clozapine has been associated with increase in pneumonia and antibiotic use. Another thing of note, lamotrigine can be associated with IgA deficiency. Again, these don't seem to be very common, but something to be aware of. So in the next section, I really wanted to kind of delve more deeply into these 4 specific types of secondary hypogammaglobulinemia, thinking they're either quite common things we deal with or the opposite. So planning to look into specifically B-cell targeting therapies associated secondary hypogammaglobulinemia, solid organ transplant associated hypogammaglobulinemia, and then review a little bit how we diagnose protein-losing enteropathy and Good syndrome. So B-cell targeting therapies are used in many conditions listed here. And again, by definition, they are meant to induce temporary depletion of B cells using several different mechanisms listed here. This is a cartoon from a paper that shows really schematic time to recovery, or depletion and recovery of B cells and immunoglobulin levels after use of rituximab. And you can see that the most commonly listed time to recover of B cells is between 6 and 9 months. if it's rituximab monotherapy, but can be longer if additional immunosuppression has been used or chemotherapy. And in terms of immunoglobulin levels, they decrease within a few months of treatment, and then it can take over a year to get back to pre-treatment levels. Now, this is, of course, a lot more complicated than that. So B-cell recovery time varies per condition and also affects different B-cell subsets differently. What we see is that conditions like the vasculitis, GPA microscopic cholangitis, or EGPA, for some reason are the ones where it takes much longer to recover B-cell counts, followed by lymphoma. That's potentially related to additional immunosuppressive treatments used with that, whereas rheumatoid arthritis or other rheumatologic conditions like connective tissue disease have a shorter time to B-cell recovery. And then, maybe not surprisingly, but looking at which B-cells take longer to recover, memory T-cells take longer than overall B-cell counts. And I think that makes sense. It takes time to rebuild that population. In terms of rates of secondary hypogammaglobulinemia, they also vary per condition. So we are more likely to see them in patients being treated for malignancy like lymphoma, quite high rates. And these numbers actually surprise me. They seem quite low. So just kind of putting it together with the previous slide for conditions, for the rheumatologic conditions, especially at vasculitis, maybe not as many patients will be affected by, will have secondary hypogammaglobulinemia, but they may take years to recover their B-cell counts after rituximab is finished, assuming that is finished. Just another consideration. So sometimes treatment for these various conditions can unmask inborn error of immunity, and so that will be something to consider in patients who have really truly delayed B-cell recovery. Again, definition of that will will depend on what they have. Persistent hypogammaglobulinemia, perhaps more infections, and also if they have other conditions that can be associated with inborn errors of immunity, like these autoimmune cytopenias or lymphoproliferative disease. And so, as I think we all know, screening for hypogammaglobulinemia or screening for baseline immunoglobulin levels is recommended by a number of societies before initiation of B-cell targeting therapies, but it is often still not done. A paper from a few years ago, it was at Mass General, where they looked at a large cohort of patients on rituximab, found that 85.4% of those patients actually did not have their quantitative immunoglobulins checked ahead of start of the therapy. So very important point. This is just a table. I thought it would be worthwhile listing the different kinds of anti-CD20 therapies, just so we are more familiar with the names and kind of what's known about how they affect the immunoglobulin level. So rituximab, we're all familiar with, used for a wide range of conditions. There's also now the humanized and human monoclonal, anti-CD20 antibodies listed here. They are the conditions like, for example, ocrelizumab is used primarily for MS, the next one for malignancies. All of those, not surprisingly, were reported to be associated with secondary hypogammaglobulinemia, although we have the most data in terms of like timing to recovery and how much it affects immunoglobulin levels for rituximab.
What's the difference between humanized and human? What does that mean?
It is how so human. Sorry, I guess I'm not. It depends on how far removed it is from. Oops, sorry. Sorry, I can't explain it very well today. It's it depends on how many parts of the monoclonal antibody are derived from, say, mouse versus how many versus human. And so the closer it is to having fully human, the different chains of the antibody, the less adverse reactions a patient would have tolerating it. Sorry, I didn't explain it very well. All right.
Okay.
And in terms of other B-cell targeting therapies, so the ones we probably don't see very often are anti-CD19. Again, those are for conditions in neurology, lymphoma, ALL. They also have been associated with secondary hypogammaglobulinemia. Anti-B-cell activating factor used for some rheumatological conditions so far has not been associated with that. Just to review in terms of how what these monoclonal antibodies target. So CD20 is expressed widely from pre-B cells to pre-plasma cells, but is not expressed on plasma cells, versus CD19 is expressed more broadly, and so the effects of immunosuppression are expected to be broader with CD19. In terms of implications for vaccinations in patients on B-cell targeting therapies, so again, with anti-CD20, as they do not target plasma cells, patients will likely maintain prior vaccine antibodies. In terms of when to vaccinate those patients, ideally would be when some B-cell recovery is seen, and so the current recommendations do so to do it at least 6 months after the last dose and 4 weeks before the next dose. And again, for anti-CD19, we do affect plasma cells, and so maintenance of old plasma cells for specific vaccines will be more affected. Patients with T-cell depletion should not receive live vaccinations. And just mention, the vaccines are still recommended in certain cases, like, for example, annual COVID vaccine, annual influenza vaccine, COVID vaccine, and sometimes Shingrix for the effects on T-cell response, even if patients are not able to mount a good antibody response. Now, what are the risk factors for prolonged secondary hypogammaglobulinemia and infections after rituximab use? So we actually don't have like 1 or 2 pivotal studies about this. A lot more information is needed, and I think that relates largely to these this being used for very different underlying conditions. There's a recent paper that it's a review which has identified some risk factors for prolonged secondary hypogammaglobulinemia. That said, a lot of them are based on small studies. There are no larger studies. But so things like low baseline IgG, as well as low baseline IgM and IgA, number of rituximab treatments have been identified as factors for that in some studies. Again, as previously mentioned, patients being on other immunosuppressive therapies can also are more likely to have prolonged secondary hypogammaglobulinemia. Now, as far as risk factors for infections specifically, again, depending on the study, they kind of similar to the risk factors for prolonged secondary hypogammaglobulinemia. I highlighted cancer here, and that's the various types of cancer, because that seems to come up more often in terms of like finding association with increased risk of infection. In one study, again, this is the large cohort study of patients who are on rituximab for various types of conditions, rheumatology, oncology. The only statistically significant increase in rate of severe infections in patients on rituximab was found in patients with cancer, that's shown here, and also in their overall cohort. Not shown here, but the association with low baseline serum IgG has trended this way, but it did not reach statistical significance. And aside, what are other possible complications of B-cell targeting therapies? So most common infections would be bacterial sinopulmonary infections, like we see with various types of antibody deficiencies. But other things to be mindful, there are viral infections, specifically enteroviral meningoencephalitis, CMV parvovirus. Latent hepatitis B reactivation has actually black box warning for rituximab and ofatumumab. The delayed neutropenia is something that I think been noticed fairly recently, and that's only been studied in rituximab, but it seems this is the kind of onset about the 35 to 175 days after dose, and it's transient, and prevalence of that is variable. I have not seen any information as to this affecting a risk of infection specifically, or we can speculate. Much smaller studies, but the reports have been published about T-cell lymphopenia. It was use of rituximab and ocrelizumab. Again, that seems to be less common, or at the very least less defined. And then also progressive multifocal leukoencephalopathy is another potential complication. Just the most recent review just mentions, is kind of highlighted here, that really further studies, including RCTs, are needed to better define the role of immunoglobulin replacement for infection prevention in these patients, just owing to great variety of what happens depending on what the condition they have. Moving on to the next, so the next part is about secondary hypogammaglobulinemia and solid organ transplant patients, and that is actually much clearer. So the association of secondary hypogammaglobulinemia with solid organ transplant is known. It is known to be associated with worse clinical outcomes, including increased infections, and it's for the most part a problem in the first year. It's also increased with 1 year all-cause mortality. So the pivotal study that looked at this is now 10 years old, but it was a meta-analysis looking at incidence of hypogammaglobulinemia infections and overall mortality within a year post-transplant. And there 45 patients developed IgG less than 700 and 15% of patients less than 400. And it did vary depending on the type of transplant, with this being most common in the lung, followed by heart, kidney, and liver. Almost all patients had, so this notes patients reaching a pretty significant hypogammaglobulinemia. Other studies did show that really almost all patients have some decrease in IgG and IgA level post-transplant, regardless of their pre-transplant levels. And again, this is also, that's why pre-transplant, they do screen for immunoglobulin levels. This is within several national society guidelines. And interestingly, on the screening in one study, pre-existing hypogammaglobulinemia was found in up to 15% of lung transplant and up to 7% of kidney transplant patients. And again, going back to this pivotal study, what is the risk of infection in patients with severe secondary hypogammaglobulinemia? So here we have odds ratios for infections, and they're all elevated, but they kind of increase the more severe hypogammaglobulinemia is. So with IgG below 400, having quite a really high odds ratio of infection. In addition to this, low IgA or IgM that together with low IgG were identified as risk factors for the post-transplant infections in several smaller studies. There is also increased risk of 1 year all-cause mortality in patients with secondary hypogammaglobulinemia, and it is much higher in patients who have severe hypogammaglobulinemia with the IgG levels less than 400 in the first year. There are variables to consider in this situation as well. So we already discussed time from transplant. So that this in most patients that is transient, and the first year is really critical. Type of transplant, and then also consideration of what other immunosuppressive regimen the patients are on, and this is a list of kind of common ones used alongside with it. So moving on to the next big category of secondary hypogammaglobulinemia, and that's protein-losing enteropathy. It's not something that I think we see often, and it seems to be a condition that's not really owned by any one specialty, but it comes up in a differential. So the definition of that is that it's any condition leading to abnormally rapid loss of serum into the bowel lumen that can result in both hypogammaglobulinemia, but also lymphopenia. And so it can be considered in patients who have edema, low serum albumin, and where all other causes of proteins loss were ruled out, such as proteinuria, malnutrition, etc. So they actually have pretty, we know there are, to diagnose it, there are some specific labs. So clinical presentation is before described, but to confirm it, demonstration of increased stool alpha-1 antitrypsin clearance is required. And here's the kind of how to calculate it. Notably, it requires 24-hour stool collection and same-day serum and alpha-1 antitrypsin. And then other labs that are used to kind of help support it listed here, like low serum protein, gamma globulins, albumin. The incidence of this condition is not known. And in terms of causes, so I actually like the table from UpToDate the best. It splits them into kind of the broad categories of who can have it into inflammatory exudates due to mucosal erosion or ulceration versus increased permeability of the gut mucosa due to mucosal disease without erosions, and then intestinal loss of lymphatic fluid because of lymphatic obstruction. And I mean, those are long lists of conditions. Notably, inflammatory bowel disease can lead to this through more than one mechanism, gastric malignancy, but also things like celiac disease or lupus or eosinophilic gastroenteritis. And here in this category, there are primary intestinal lymphangiectasias, but there's also things like heart failure, which can result in this process. So just my take on it is that it appears to be relatively rare, even though it's associated with many conditions which are not uncommon. And so it's one of those very curious conditions as to why it happens. There's a recent paper from a European group where they were trying to find out maybe if there are some ways where we can distinguish more definitively between CVID and protein-losing enteropathy, or maybe define patients who have both, which is difficult because ruling out protein-losing state is one of the diagnostic requirements for CVID. And so they asked this question: can CVID and protein-losing enteropathy co-occur? And they had this retrospective study where they decided to divide patients into 3 groups, and they defined CVID and protein-losing enteropathy as meeting all the diagnostic criteria for CVID except for the not having protein-losing state. And patient had elevated alpha-1 antitrypsin stool clearance. CVID only straightforward, they would not have protein-losing enteropathy. And then for the protein-losing enteropathy only group, they decided to choose causes of protein-losing enteropathy that are not typically associated with CVID. So with those groups, they did find that for the patients with CVID only or CVID and protein-losing enteropathy, by testing, those patients had more infections and lymphoproliferation as opposed to patients with protein-losing enteropathy only. Also for patients who had CVID only versus protein-losing enteropathy only, they also had more abnormalities on their immune workup, such as lower overall levels of IgG, IgA, fewer naive T cells, decrease in memory switched B cells. And then in the CVID, comparing the CVID with protein-losing enteropathy versus just protein-losing enteropathy group, they had specifically lower IgG and lower memory switched B cells. Potentially we can tell apart, patients who have both CVID and protein-losing enteropathy, though it still remains quite challenging because there's a lot of overlap in their immune parameters. And to review it, kind of the last condition I want to mention in this category, Good syndrome. It's an adult onset acquired immunodeficiency characterized by thymoma and hypogammaglobulinemia. It is very rare. Certainly not all cases have been reported, but the most recent literature review identified 162 cases. And it's one of those secondary immunodeficiencies where, again, it has many different immune defects associated with it. The exact cause of what's causing the immune dysregulation is not defined, but it is thought that thymoma, an abnormal T cell development due to abnormal thymic environment, leads to having both T cells and subsequent B cell immunity defects, resulting in both impaired T cell function, B cell lymphopenia, and certainly hypogammaglobulinemia. And so presentation can be very heterogeneous. Some patients are not symptomatic, but they can have frequent and severe cytopulmonary infections and also autoimmune disease. So moving on to the next section, and that's really focusing on management of secondary hypogammaglobulinemia. And this is the paper that I've been citing a lot throughout this presentation so far. It's the practical guidance on diagnosis and management of secondary hypogammaglobulinemia from the Quad AI, and it's a great resource. So in terms of workup, we've gone through this. It's pretty straightforward, pretty self-explanatory. Thorough history is very important. We should confirm hypogammaglobulinemia, so don't just go off just a single measurement. We demonstrate sustained. Check other things other values that have been oftentimes abnormal, IgA, IgM, vaccine-specific antibody titers, lymphocyte subsets. Then depending on clinical history, a number of other studies can be considered to work this up. This is a very busy figure, but it's a really good one. So these are our society's Quad AI's recommendation on who should be screened for immunoglobulin levels. And so that would be any patient before start of B-cell targeting therapy, any patients with diagnosis of lupus and before starting immunosuppression, any patients preparing for solid organ transplant, patients at the diagnosis of CLL, before starting CD19 CAR T therapy, and then some other hematologic malignancies that can affect B cell numbers and function, before stem cell transplant, and also consider this in patients with severe pulmonary disease, not such as COPD with frequent exacerbations, bronchiectasis, and not surprising, anybody with recurrent severe unusual infections. And there are some recommendations on how often, so you do this, you do screening before or at the diagnosis of these conditions, and there are some recommendations also how frequently to screen afterwards, because hypogammaglobulinemia can change depending on the condition. Some of it can improve after it's treated, and so what the patient may need will change over time. So it's a very nice reference here. In terms of recommendations on management, so there is a large flow chart in that paper, and this is just a simplified version of it. Who do we recommend immunoglobulin replacement for? And so the first decision point is history of recurrent severe unusual infections. If that's the case, then we follow this pathway. If no, then this one. The next point of consideration is how severe is the hypogammaglobulinemia. Excuse me. So it's considered severe if it's any hypogammaglobulinemia was IgG less than 700, was associated non-IgG hypogammaglobulinemia and suboptimal responses to vaccination, or if it's isolated IgG of less than 400, and this coming primarily from the solid organ transplant studies. So if the patient say were to have frequent recurrent severe infections and they do meet this hypogammaglobulinemia cutoff, or so if they don't, then trial of prophylactic antibiotics can be considered. But if they are hypogammaglobulinemic, then trial of immunoglobulin replacement therapy is recommended. Now it's also possible and oftentimes recommended to start immunoglobulin replacement therapy even if there isn't history of severe recurrent infections. And again, this really is very variable, but one cutoff of IgG that's been recommended is less than 150. In that case, the QuadAI committee does recommend trial of IGRT. Otherwise, if patients have, again, this significant hypogammaglobulinemia, shared decision-making can be used depending on the case. Versus if they don't, then clinical monitoring is recommended. So this is very helpful. That said, it's still not like a roadmap saying very clearly, for every patient, what should be done. But it's good guidance to have. I think this. I suspect we're all familiar with. So how do we replace, how do we do immunoglobulin replacement therapy? It's the same as in primary immunodeficiencies. So typical starting dose would be 400 to 600 milligrams per kg per month. There isn't any, for the most part, there isn't any preference if it's IV or subcutaneous. There are some specific condition-specific recommendations for use of SCIG, which I will go over. But for the most part, it can be either form. And they recommend checking IgG trough 3 months later to adjust. And they do mention starting goal IgG trough of 800. I actually did not find out what that was based on, but it's a good number. And then, of course, adjust per clinical response. Other considerations, side effects and also patient perspective, among other things, that's very important, especially in those situations where patient does not have like does not have the clear-cut indication to start this. So that's where the shared decision-making comes into play. And patient with the same clinical history we may end up doing different things depending on all these other factors. Things to remember is that the need for the immunoglobulin replacement can be temporary. The guidelines recommend to consider pausing it if immunosuppression is discontinued, for example, 9 to 12 months after stopping things like rituximab, or if the underlying condition has been treated. And so periodic assessment every 6 to 12 months is recommended. And then a reevaluation of immune function 3 to 4 months after stopping immunoglobulin replacement therapy is another recommendation. The guidelines have sections that go into a lot more details into management in specific conditions. I just put the highlights out here for your reference, but there's a lot more details in that paper. So for CLL, it actually is the only FDA approved indication for use of IVIG in secondary hypogammaglobulinemia. That said, whether it's used or not every patient will be treated. So really would follow the flow chart we just reviewed to determine if they might need it. For lymphoma, CLL guidelines are followed. There is less information in terms of multiple myeloma and how helpful immunoglobulin replacement therapy is in there. But so again, we would fall down to the flow chart recommendations. With the CD19 CAR T therapy, in the first 3 months, many patients will have severe hypogammaglobulinemia, and so if they do, that would generally be recommended. I think we already covered the solid organ transplant, but again, such screening before is recommended. The guidelines do recommend actually working with a clinical immunologist to help make decisions about need for immunoglobulin replacement therapy. And some papers suggested lower cutoff, like IgG of 350, and poor vaccine antibody responses to start this. In terms of rheumatology, so yes, we kind of discussed that before. American College of Rheumatology has its own guidelines in which they recommend IgIT for patients with GPA or microscopic cholangitis if IgG is lower than 300 and they have recurrent infections, or if they have no infections but have impaired vaccine antibody titers. Again, the Quad AI guidelines are a little bit different, as we just reviewed. And so we will have some discussions with our rheumatology colleagues and just going to use shared decision-making in managing those patients. In neurology, there's really not a lot of data. So it again, not really clear in patients with neurological conditions such as MS, if the secondary hypogammaglobulinemia is due to underlying disorder or treatments. The decision to use immunoglobulin replacement therapy has been mainly driven by the primary immunodeficiency literature, and a lot more information is needed to get more detailed guidelines. Now, in pulmonary conditions, immunoglobulin replacement therapy does not play a big role. What they in COPD, it's not routinely recommended, not surprisingly. However, patients with severe COPD with frequent exacerbations should be screened for potential associated antibody deficiency. And so if they do have that, then of course, it could be considered. Really no role for screening for antibody deficiency in asthma. Cystic fibrosis is interesting because there are some immunoglobulin level abnormalities. Hypergammaglobulinemia is more common, but hypogammaglobulinemia has actually been reported in patients depending on a study between 1.9 and 10.8%. But it doesn't seem to be associated with increased risk of infections, or at least that's not been documented, and it actually is associated with milder lung disease. So like right now, there isn't sufficient evidence to start immunoglobulin replacement therapy for hypogammaglobulinemic patients with CF. For protein losing states, I mean, for the most part, it would be very difficult to keep up with the protein loss, and very rarely is this done. The guidelines official stand is that there is insufficient evidence to recommend immunoglobulin replacement therapy due to lack of good quality large sample studies. For nephrotic syndrome, again, very difficult to circumvent protein loss, even with supratherapeutic doses. People have tried using subcutaneous delivery method, but that was also not found to be more effective. There's also some concerns how it affects already tenuous renal function, though sucrose-free IVIG preparations were shown to be safe. With protein-losing enteropathy, the recommendations are that we can consider replacement if patients have frequent infections and have not done well with antimicrobial prophylaxis alone. And in this setting, subcutaneous immunoglobulin replacement, it looks like it is more effective in maintaining adequate IgG levels. In lymphangiectasia specifically, the good news is that even though these patients have hypogammaglobulinemia and lymphopenia, clinically significant infections actually are not common. And so prophylactic antibiotics or immunoglobulin replacement is not routinely recommended. In terms of good syndrome, so this actually was not in the part of the Quad AI guidelines. I just want to bring it up. It's a rare condition, but expert opinion actually does recommend using immunoglobulin replacement therapy for those patients. The reason being they get severe infections, and most of them get them. So in this largest published a review of various good syndrome cases, 92.6% had infections reflective of combined immunodeficiency defects, and infections were the main cause of mortality. And this is far from definitive evaluation, but they did comment that, between this review from 2020 and one from 10 years before, looking at newer studies where patients perhaps got better supportive care, the mortality also improved. And so to finish, we still have a few minutes. I just brought up a couple of cases just to kind of make us think a little bit about specific examples. I'm sure everybody has many many examples to bring up. But so the first case is also show a secondary hypogammaglobulinemia in a patient with solid organ transplant. So this was a 66-year-old gentleman who underwent lung transplant for idiopathic pulmonary fibrosis. He was on immunosuppression with mycophenolate, tacrolimus, basiliximab. He's had many complications, not just infections post-transplant, but at 7 months was admitted, among other things, for treatment of infections with multi-drug resistant CMV viremia, and also pneumonia with several organisms isolated. And so we are consulted for consideration of IVIG in this patient. And so looking at his workup, this was a patient who had no hypogammaglobulinemia before transplant. He developed it within the first year, and it was around 370 to 400. And so for this patient, we did recommend a one-time dose, but also expecting that he will likely improve in terms of his immunoglobulin levels. No scheduled redosing was recommended. And in fact, his IgG levels have normalized on subsequent subjects. So he did not require ongoing management with IVIG. This is a case of a patient with
Ania,
yeah.
why did you predict he was going to normalize on his own?
There's a lot of data on kind of trajectory of hypogammaglobulinemia and solid organ transplant, and it really, for most patients, it is most notable in the first year, and then as time goes by, they do improve. Probably large part of it is because they recover from the initial kind of more heavy immunosuppression. But yeah, we just natural history of this. We expect most patients to improve. Yeah. So here's the patient with CLL. So this was a 64-year-old gentleman who was referred to clinic for consideration of immunodeficiency. He had sort of early onset ulcerative colitis as a teenager, more recently developed interstitial lung disease and pretty significant hypogammaglobulinemia. And so with him, we actually were concerned about inborn error of immunity. However, his workup unfortunately led to diagnosis of CLL. So he had elevated B cells. B-cell immune phenotype indicated high likelihood of monoclonal population, which was confirmed later on. This patient had protective titers to tetanus vaccine, but he actually failed pneumovax vaccine. And so following our flow chart in these guidelines, he falls into the sort of the shared decision-making category. And for this patient, he was amenable to starting immunoglobulin replacement therapy. In terms of follow-ups, obviously treatment for his CLL was the most pressing issue, and he was referred for that. And with the plan to reevaluate the need for immunoglobulin replacement therapy pending his clinical course. This case, it's a patient with ANCA vasculitis on B-cell targeting therapy. So this is a 66-year-old woman. She has MPO positive ANCA vasculitis with renal sinus pulmonary involvement. She was previously on maintenance rituximab. It was stopped a year ago. She remains on azathioprine. She has hypogammaglobulinemia and follows in our clinic. In terms of her infectious history, so it's not significant, so to speak. She had a prolonged sinus infection when she was first diagnosed with her vasculitis, and only recently had a kind of prolonged, difficult to treat sinus infection, but nothing else. This patient, unfortunately, did not have her pre-treatment IgG levels checked, but since she has been on rituximab, her IgG and IgM have been low, and the IgG has been sort of trending down over the years. She had, again, protective vaccine titers to tetanus, but not to pneumonia vaccine. And she also had numerous lymphopenias, most notably B cells, not surprisingly, because because of her rituximab therapy, though so far it has persisted at this level for a year. Again, from what we reviewed, it's actually not entirely surprising for patients with this condition. So it's possible she may still recover. But so for this patient, again, she, following the flow chart for do we treat or do we not treat with IGRT, shared decision-making. For this particular patient, we are monitoring her clinically. A lot of it is, due to concern for basically patients' sort of personal goals of care played a big role in making this decision. I guess difficult part about this case is, is this new infection a harbinger of more infections to come in setting of her dropping IgG levels? So again, it's a patient that we are watching very closely with labs as well as clinical course. This one, this was the case that really made me think about protein losing enteropathy a lot harder than I normally would have otherwise. So this is a 30-year-old patient who was referred for hypogammaglobulinemia. So she has very interesting history. She has congenital heart disease, truncus arteriosus, which was repaired when she was a baby. She's never had any heart failure symptoms, and even though she, despite this, she just follows annually with cardiology, but never needed any treatment aside from what she already received. She was interestingly not tested for 22q11.2 deletion. That's very commonly associated with truncus arteriosus, but it was deferred when she was young due to low suspicion. She does have congestive hepatopathy, though this was more of an incidental finding on imaging, and then had recent onset lower extremity and abdominal edema. She doesn't have any significant infectious history. She also had no proteinuria. Her renal function was normal. So on her labs, she had really low IgG, but normal IgA and IgM, and panlymphopenia, and also very low T cell and B cell, particularly CD4 lymphocyte counts. Because very unclear what's causing this in this patient. However, she did meet the criteria for protein losing enteropathy based on her fecal alpha-1 antitrypsin stool clearance. Her cardiology team is very confident that her congenital heart disease complications are basically not causing any issues. Her findings on echo and cath were stable, and so I mean, for this patient, she was not recommended to undergo immunoglobulin replacement therapy. She's undergoing further workup with GI to really look into evidence of something in her GI system leading to protein-losing enteropathy. I didn't mention she has not had really any GI symptoms. She does not have diarrhea. So still remains a mystery as to what's causing this in this patient. Sorry, and this is a mistake here. This is actually a high protein diet, not low protein diet. So that's one of the interventions that was recommended for her, and we'll monitor her closely. Also, consideration of PJP prophylaxis. This patient has very low CD4 counts. Again, we don't have data in this patient, in this kind of patient presentation, are they really at higher risk for this, but something to consider. And actually, I think with her, she actually decided to proceed with that out of caution. Okay, I've last case, very brief one. This is a patient who has hypogammaglobulinemia and thymoma. So this is a 76-year-old woman, had a 10-year history of really kind of symptoms that were not attributed to anything in particular. She had lower extremity weakness. It was suspected to be due to autoimmune myopathy, but she didn't meet the diagnostic criteria for myasthenia gravis, and in the end did not end up getting any specific neurological diagnoses. She was found to have anterior mediastinal mass, most consistent with thymoma, and was referred to us for hypogammaglobulinemia, which is shown here, pretty significant. She has not had any infectious history. We do not have any of her immunoglobulin levels prior to this. She also had poor responses, poor vaccine-specific antibody titers. And so for this patient, immunoglobulin replacement therapy was recommended, and she's on it and doing well. Otherwise, we are monitoring her immune parameters, and resection of her likely thymoma was recommended, though this particular patient, for understandable reasons, is hesitant to undergo invasive surgery, so has not done so yet. So just quick take-home points, keep broad differential in evaluation of secondary immunodeficiencies. Don't forget about inborn errors of immunity in a differential. Also, keep in mind kind of the rare causes like the Good syndrome or protein-losing enteropathy. The decision about initiation of immunoglobulin therapy is individualized and complex, but we do have some nice guidelines to fall back on. And notably, use of immunoglobulin replacement is favored in some patients with secondary hypogammaglobulinemia, even without significant infectious history, as we kind of went over. My references are in here, and this is the word of the day. And I think we still have a few minutes for questions.
Well, thanks, Ania. I'm glad you're on top of this topic. I'm certainly not. One simplistic question, it would seem to me that giving gamma globulin replacement to people with protein-losing enteropathy is a losing proposition. You put it in one end and it comes out the other. It's just wasted. Is that too simplistic?
It's not, agreed. It's just, if it comes to this individual treatment, I think, especially in those, especially in patients who also have other, potentially have coexistent CVID and really had severe infections. I think that was attempted, and that's where the subcutaneous IG seemed to work to some extent, but no, for the most part, it would not be recommended, especially if somebody doesn't have infectious complications.
We got any other questions or comments? I think it's just about